talking about the topic, what I will cover, first of all, what is a normal cardiac rhythm and how we assess it, because I think Bettina gives a talk tomorrow about bradyarrhythmias, but I will give you some clues how to assess cardiac rhythm, and then the main reasons of an irregular and or fast rhythm. So as you probably all know, the heart is a pump, and to be able to pump you need electricity, and the electricity normally starts in the sinus node, travels through the atrium, through the AV node, where the electrical conduction is slowed down, then down to the interventricular septum, the Purkinje fiber, to activate the atrium and the ventricle one after the other. There's a normal heart rate range, and I would like to show you this in particular, what are normal ranges for gestational age. And this is what is considered a bradyarrhythmia by obstetricians. It's clearly not correct. It's less than the third percentile for gestational age. If you have a persistent arrhythmia, a persistent heart rate that is lower than the third percentile, that's not normal. 110 is far too low. Bettina will, I'm sure, talk about long QT tomorrow in length. What you should be seeing, this is the cascade, how this is activated. So the atrial rhythm in the fetus is very regular, within a normal range, and the AV conduction allows the ventricle to be activated also regularly at the normal rate and the normal time interval. Now, unfortunately, we don't have, most of us will not have an ECG before birth. There are a few centers that have it, a fetal magnetocardiogram. My hospital director didn't pay me one, so I rely on echocardiography like everybody else. So what we are looking for are correlations or relations between electrical activation and mechanical events. So every time the atrium is activated electrically, it will contract. And there are a number of markers that you can take that relates to it, like the Doppler inflow, the A wave, like the flow reversal in the SVC when the atrium contracts. Every time when the ventricle contracts, you will have forward flow in the aorta, as an example, or you will see an M mode, inward motion of the myocardium. And we look at this mainly with M mode Doppler. Ideally, you go from the free wall to the atrial wall and the ventricle wall, and you see how the atrium is contracting and how the ventricle is contracting. And if you stop it, you see that this is happening very regularly in a normal time interval. Every time the atrium contracts, a ventricular event will follow. A little bit more difficult to obtain is the SVC aorta Doppler, but it's relatively easy if you are aware what to do and have practices a little bit. And I think it's actually a better technique, or at least in combination with M mode, it provides the additional information. What you can see is that the SVC and aorta are neighbors. If you put your Doppler sample volume over this area, every time the atrium contracts, you get flow reversal in the SVC. Every time the ventricle contracts, you have forward flow. This is sagittal plane, but where I can nicely show this to you. But frankly, it works also in a four-chamber view, a little bit tilted up, and you will very frequently get the SVC Doppler signal too. Look at the flow pattern. The aortic flow is, here blue, is pulsatile. But also the SVC flow looks actually pulsatile. And that's related to that during atrial contraction, the forward flow to the heart stops, and there's a reverse flow. So it looks pulsatile. It's not an artery, it's a vein. This is the Doppler flow pattern here, the venous Doppler flow pattern here, SVC, and the ventricular contraction with the ejection in the aorta flow. So it looks like an ECG a little bit. The A are the P waves, and the V the QRS waves, and you can actually measure time intervals. But what is normal is short AV interval at the long VA timing. I will come to this because it's relative what we use, unfortunately, in tachyarrhythmia classification is the VA duration. A very good tool, too, in my opinion, and I neglected this myself a little bit, is looking at the ductus venosus flow. As you know, there should be antegrade flow through the cardiac cycle, during ventricular contraction, early diastole, but also when the atrium contracts. But still you have an idea about the regularity of atrial events just by looking at this. So very helpful, in particular, if you suspect an atrial arrhythmia. This is just a little bit what I look every time, automatically. I'm not doing every time these measurements, a lot is eyeball. But the normal rate, regular rhythm in the atrium and the ventricle, this is normal. Every atrial event precedes a ventricular event. That's what we call a 1-to-1 AV ratio. If you have more atrial event than ventricular events, there's a problem is an arrhythmia that comes from the atrium. You have more atrial beats. Every time you have ventricular events that are more frequent than atrial events, if you look them on a tracing, the arrhythmia must come from the lower chamber, from the ventricle. If there is no relationship between atrium and ventricular events, we call this AV dissociation. Very important assessment of cardiac rhythm, and you do this automatically, is how does the cardiac function look like? Is there any effusion? Is there any valve regurgitation? And if a baby has a severe form of arrhythmia, how is the baby moving? Because sometimes baby has stopped moving some days before, and this is a critical period of time where you have to act immediately, potentially even with direct treatment. Structural heart disease, the Epstein's, I hear this all the time. Frankly, it's extremely rare to have Epstein's with arrhythmia before birth. It's common after birth. 15% of Epstein's patients will have arrhythmias before birth. It's actually quite unusual. But there are other forms, left isomerism with complete heart block as an example. Then the history of the family. Is there any history of a channelopathy, connective tissue disease, maternal antibodies, Graves' disease, so thyrotoxicosis, are all factors you have to take into account to get an idea what might cause the arrhythmia. Let's start first with the benign one that I, frankly, as a fetal cardiologist, don't necessarily want to see before birth because they're in general benign. There are a few exceptions. So what you see is an irregular rhythm, and this is typically related to either premature atrial complexes or beats or premature ventricular beats. PACs are far more common than PVCs, and they can be quite annoying because you get a very regular rhythm and everybody is nervous. But what you can see in our patient is that these are really PACs because you have more atrial events than ventricular events. This one seems to be conducted, this one too, there is no contraction. So this is what we call a conducted premature beat, and this is a blocked one. And the reason why some are blocked and some are conducted depends if the AV node is able to conduct the premature beat from the atrium to the ventricle. The AV node functions sort of as a filter, very short, very early onset of a premature beat. The AV node is not ready to conduct. That's why it's blocked. If it takes longer, it can conduct. You see this here. So this one is a little bit a longer interval. I assume it was conducted, and this one blocks in the AV node. And you have more atrial events than ventricular events. Pretty common, one of the most common arrhythmias you can see before birth. The diagram here on top shows a conducted one, so premature beat somewhere from the atrium, and the electricity crosses the AV node down to the ventricle. And then you have a pause, because the sinus node comes back and takes over again. And look just at the filling pattern. The premature beat has a little bit less ejected blood, so your velocity time interval here is lower than the beat that comes after, because the heart has more time to fill. So you see also differences there. This is a blocked one, so you see an atrial event immediately after the ventricular event, and then a pause, so skipped beat. A little bit more annoying sometimes is when they come with atrial bigeminy, because they can look like complete heart block or 2-to-1 block. The main difference is that the atrial interval are regularly irregular. So this is short, that's the premature beat, not conducted, long, again short, long. And this is a very regular rhythm, even if it's an ectopic rhythm. What you see down here, so these babies typically have heart rates in the range of 65, 70 beats per minute, and this can last for days, and is, however, completely benign. It will go away. So briefly about premature atrial contractions, most common cause of an irregular heartbeat, usually no underlying cause identified. I'm sure each of us has, if you do a Holter, premature extra beats. It is pretty normal to have that. It's benign, self-limiting, but there's 1% progression to SVT, and that's why we recommend following these patients, in particular if there is bigeminy. Even the blocked atrial bigeminy that I showed you potentially is at risk of going into SVT. And what I do if I see very frequent PACs, particularly bigeminy pattern, I actually give them heart rate monitor and send the patient home, tell them to come back and let us know if they pick up fast heartbeats. This was one with non-conducted or conducted PACs, so this is premature and was conducted again bigeminy. We give them some more heart rate monitor. This one is no more Health Canada approved, so don't buy that one. FDA might be, but this patient came back with intermittent SVT and then incessant SVT and needed treatment. So it's quite easy to give the heart rate monitors to check, and it's probably better than just to send somebody for weeks just for follow-up and not knowing what's going on. Can save time. So as you have seen already a fast heartbeat, let's talk about the fast heartbeats. On the left one is one with a massive rhabdomyoma. Fortunately, not something we see very often, that uses the tumor mass as an accessory pathway. So electricity going to the center of the heart and returns through the muscle to the atrium, so a re-entrant tachycardia. And this one has a faster atrial rate than a ventricular if you look very carefully, so atrial flutter. Fetal tachyarrhythmias are defined as fetal dysrhythmia with atrial and or ventricular rates above 180. You can have an atrial flutter at a rate of 400. With 4-to-1 conduction, you end up with 100 heart rate, so bradycardia, still a tachyarrhythmia, even if the ventricular rate is low, as an example. It's not very common, but I think each of us is seeing patients with this. The most common mechanism is what we call re-entry. Re-entry means electricity recircuits around an area, the same area that has been excited before, within the atrium, atrial flutter, or between the atrium and the ventricle across an accessory pathway. They are 90% of all arrhythmias are related to re-entrant circuits. But again, talking about ectopy, focal tachycardia, where you have an ectopic focus that fires faster than normal, can be a mechanism of a fast heartbeat, and it's most commonly what we call atriectopic tachycardia. So electrical cells that fire faster than the normal sinus beat and take over, and they account for about 8%. The other ones are relatively rare, and I will not talk too much about this. Why is it important to differentiate the arrhythmia? For a number of reasons. They will guide your treatment, but they will also inform you on the risk of a fetus going heart failure. The most commonly we see fetal eye drops related to what we call AV reentrant tachycardia. And I will explain you in a moment why. Atrial flutter, if we see high drops, it's usually not such a good prognosis, because atrial flutter is also more difficult to treat and get back to normal rhythm. We usually don't see it with AET and PGRT, even if they're the most annoying arrhythmias before birth, because they're more difficult to treat. But they can last long, and the babies usually tolerate it. I mentioned you can have cardiac tumors, you can have structural heart disease with this. Again, it's mainly seen with ERT and atrial flutter. So what is atrioventricular reentrant tachycardia? This is what we call a short VA tachycardia, and it is because the electricity goes from the atrium through the AV node, relatively slow, but is conducted backwards fast through an accessory pathway. In this situation, the time interval between ventricle contraction and atrial contraction is short. The atrium contracts against the ventricle that has just contracted, so you get a lot of flow reversal. And this is the reason why these babies become hydropic. But they are also fast. Their fastest rates are usually, ventricle rates are usually AVRT. 250 to 70 heart rate is almost certainly not one of the other arrhythmias. It's diagnosis you make in the second and third trimester, and it's very often it's incessant. And this is the latter diagram. So it goes down from the atrium to the ventricle through the AV node, relatively slow, but back up to the atrium through the accessory pathway fast. It's always one-to-one, because the AV node is part, and the accessory pathway are part of this reentrant circuit. This is an example of a patient who clearly didn't tolerate it well. A lot of effusion, dysfunction. There's also significant AV valve regurgitation if you put the Doppler on. I just want to show the tracing. What you see is that the VA interval is short compared to the AV interval. That's what we call a short VA tachycardia. If you are not familiar with this technique, there are other techniques like M-mode you can use, you get the same pattern. The arrhythmias, the AVRT typically blocks in the AV node. So the last, if it stops, you see an atrial contraction, but the ventricle is not conducted. That's how the arrhythmia terminates. Then you have 1 beat, 2 beat normal, and then the baby restarts with this reentrant tachycardia. But this is very helpful. If you see this, this is a AVRT. That's just shown here. I mentioned that I neglected myself a little bit the Doppler, but they are extremely useful, because when the atrium contracts immediately after the ventricle, you get a lot of A wave reversal. This is the typical flow pattern in the ductus venosus of an AVRT. It's almost pathognomonic. You can bet this is an AVRT. Look at the pulmonary vein, same thing happening. So the ventricle can't fill because it is contracted. The MCA Doppler is very irregular, and you can see eyeball already, the red and blue flow in the pulmonary veins and the ductus venosus. So atrial flutter is the second most common arrhythmia related to re-entry within the atrium. The ventricle is, the AV node is not part of the arrhythmia circuit, but it allows every second beat normally to conduct from the atrium to the ventricle. If the AV node would not function as a filter, you will go have one-to-one conduction, you would not survive this. So if we have atrial fibrillation and we would have an AV node which doesn't block it, we would be dead. Okay, so it's very good to have an AV node that is not conducting fast. This is the third trimester arrhythmia. You will not see an atrial flutter in the first or second trimester. It's almost definitely a late gestational diagnosis because the re-entry circuit needs a certain size. The heart is too small to allow a re-entry within the atrium to happen, unless maybe you have an Epstein's with a huge dilated atrium. It's typically the relationship is 2:1, so it turns around twice in the atrium and once goes to the ventricle, and the ventricle rate is in the range of 220, the atrial on average about 440. It's almost always incessant. Here is an example how we do this, and I like M mode. I usually like SVC autodoppler, but for the flutter, it's very nice to show the flutter wave on the back of the heart here. And you see this is twice as fast as the ventricle rate on top. Again, a very characteristic Doppler flow pattern also in the ductus venosus, which reflects this rapid atrial contractions. You have a lot of very brief atrial contractions, but the flow is continuously antegrade. It's not reversed like in the AVRT. Same you see in the pulmonary vein Doppler. Again, the MC middle cerebral artery Doppler is usually consistent, shows you about the same flow pattern. Atrial ectopic tachycardia is related to a focus that fires too fast, and it's like sinus rhythm. Basically, it goes down rather than from here. It can also be sinus tachycardia. It's just a faster atrial rhythm that has taken over the sinus node, and what you get is a long VA pattern, like you see normally during sinus rhythm. So the electricity goes down, the AV node, and then fires again. Permanent junctional reciprocating tachycardia is an arrhythmia where the accessory pathway is slow conducting. That's why you get the long VA interval. If I see a first trimester fetus with a very fast heart rate, it must be a focal tachyarrhythmia. An AVRT and atrial flutter, the hearts are simply too small to allow the re-entry, unless you would have a very abnormal myocardium. They are slower, they're better tolerated. As I mentioned, they're usually a nuisance to get back to normal, but they are eventually you get them back to. Here is an example of one that is not very fast, 190 beats per minute, and otherwise a normal heart. And if you look at the AV-VA duration, you see VA interval is much longer. So from the onset of the ventricular forward flow, the onset of the atrial contraction is much longer than the AV interval. So typical long VA tachycardia. I can't make the difference just by looking at this between atrial ectopic, PGRT, or inappropriate sinus tachycardia. I can't make that because I don't have an ECG before birth. The flow pattern is again different. In the ductus venosus, it looks like a normal ductus venosus flow, just much faster. Pulmonary vein Doppler, same, and middle cerebral artery with Doppler flow is usually somewhat reduced because your cardiac output is lower. For the sake of completeness, I bring that up. Ventricular tachycardia. Ventricular tachycardia is explained by increased ventricular automaticity, which means the focus is not in the atrium, like AET, but is in the ventricle, and the ventricle fires at a faster rate than the atrium. Usually you don't have conduction across the AV node backwards, and then you have an atrium that doesn't know what happens in the ventricle. And what you see is a very irregular atrial rhythm, and it's very irregular here to the ventricular rhythm, but much faster. We don't necessarily know what causes it. Often we settle with the diagnosis idiopathic, which means we have no clue. But long QT, if it's bradyarrhythmia, AV block linked, especially if their bradycardia normal rhythm might be a cause, inflammation of the heart and cardiac tumors. This is just showing you the MO through the atrial wall and the ventricular, showing you that the atrial rhythm is regular. Now, ductus venosus flow is very regular because there is no relationship between atrial and ventricular contractions. So it happens randomly. The atrium beats just at its own rate and ventricular at its own rate. So you get this very different flow patterns within the ductus venosus, pulmonary vein, but also the filling of the ventricle, the ejection varies with every beat. So you get also highly variable flows in the middle cerebral artery and in every great artery if you look at it. So one of the controversies is now what you do if you have this. I'm not covering now the PACs, which are benign, you don't need to do anything, but talking about tachyarrhythmias. There is no consensus among many of us who to treat and not to treat, and also not about the choices of medication. These are the medications that are given somewhere in the world for this condition, and drug combinations are used. But there are a number of factors that influence the decision to treat. One of them is gestational age. A young fetus is more likely not to tolerate this than a late gestational fetus. Then the arrhythmia mechanism, I told you already, AVRT is far more likely to develop high drops compared to an AT. Then what you see, if there's effusion, cardiac dysfunction, the baby has developed polyhydramnios, that all plays a role. Other abnormalities. Another thing is the mother should be healthy. You don't want to treat a mother who is at risk to develop significant problems. I do a number of preliminary work to be sure this is tolerated when I decide to go on treatment, including ECGs. We don't do routine echocardiograms, but some centers do. Not to treat, I would closely watch our brief, well-tolerated rounds of tachyarrhythmia, again giving them heart rate monitors, because then you get an idea how frequent this is. More than brief, very fast arrhythmias or tachyarrhythmias with fetal high drops, I would definitely treat or consider treatment and discuss it. Incessant tachyarrhythmia at term, if a plan for C-section delivery would be, I don't think I necessarily need to treat, but you can have, you can start treatment even at 36 or 37 weeks because you avoid an unnecessary cesarean section if it works. What you would like to achieve is obviously a normal rhythm and slow down the tachyarrhythmia to normal rate. What you don't want are severe adverse events, death of, in the worst case, both patients, mother and the child, prematurity, and the risk related to surgery. There is controversy about what medication you should start. I just bring up this meta-analysis that compared digoxin versus flecainide, digoxin versus sotalol, and flecainide versus sotalol for any type of arrhythmia. And according to the meta-analysis, it favors flecainide over ditch and sotalol over ditch. However, when you look at AVRT, it seems to be that flecainide is the better choice as first-line medication compared to ditch and sotalol. There is a trial that many of you might know about where we look into this. We have right now 380 patients recruited there, and I hope we will have the data next year to look at this. It looks at observational cohort of patients where the physicians decides treatment and the randomized clinical trials. I'm running late, so I will not go too much into it. I think the main, what I can share right now is that most patients, irrespective of the SVT, with or without high drops and atrial flutter, most of them we are able to cardiovert, but it takes time. You need to have patience. You can't rush it. You can't expect a fetus to respond within 2-3 days to antiarrhythmic treatment. survival is excellent with flutter and SVT without hydrops, and no surprise, with hydropic patients you have a problem. So persistent cardioversion in conclusion can be obtained in most pregnancy with prenatal treatment. Mortality was low if there's no hydrops, but relatively high if there is SVT with fetal hydrops. And actually we had almost no significant adverse events. Thank you.